Good morning, afternoon, or evening, depending on where you're tuning in from. My name is Lindsay Brown, and on behalf of Beyond Clean, we would like to welcome you to this collaborative webinar sponsored by DryScope Aid. With this unprecedented pandemic comes significant risks to healthcare professionals, and this webinar program will review current evidence-based practices necessary to maintain personal safety for sterile processing professionals. As a sterile processing technician myself, I am certainly excited to hear this information and also very excited to introduce you to our speaker today, Dr. Hudson Garrett. He is the president and CEO of Community Health Associates, LLC, and has a faculty appointment as an adjunct assistant professor of medicine in the Division of Infectious Diseases at the University of Louisville School of Medicine. He also co-founded the nonprofit Infection Prevention Institute to help shepherd dissemination of best practices of infection prevention and control across the healthcare continuum of care globally. He holds a graduate certificate in infection prevention and infection control. Dr. Garrett led the development of the first and only core infection prevention and control and antibiotic stewardship certifications and certificate of mastery programs in post-acute care settings. He's served on national boards in the areas of environmental services, dental infection control, acute care infection control, post-acute care infection control, and vascular access. He's served on panels related to disinfection and sterilization with both the FDA and the EPA. And Dr. Garrett has lectured in more than 25 countries and given testimony to government and regulatory agencies on various topics related to infectious diseases. Dr. Garrett's full speaker bio can actually be found in the speaker bio widget on your screen right now, in case you care to read more. And again, thank you so much to our sponsor, DryScope Aid. And with that, I'd like to turn it over to Dr. Garrett.
Perfect. Thank you very much. And good afternoon or good morning to each of you, depending upon where you're calling in from. I am extremely excited to actually go over this information because, as she mentioned, there's so much misinformation out there about this topic. And hopefully by the time you leave today, you will have a couple different strategies. One is a strategy to keep yourself safe. And your family. I think that's extremely important. Number two is I hope you have a strategy for your own workplace environment. And then lastly is how do we protect our patients? I did want to mention this small disclaimer, and I'll mention this at the end of today's program as well. Since this information is changing so rapidly, we want you to always refer to the CDC website for the most up-to-date information. I'm going to go through a couple tips and tricks of finding that information, but I did want to make sure that you realize that was out there as well. So our formal objectives for today are to really look at where we are today and specifically where are we going in the future. I think to me that's probably one of the biggest questions is what is the new normal and how do we get there? We're also going to look at some of the evolving regulatory guidance out there in clinical guidance, especially things coming from CDC, AMI, SGNA, ARN, and other organizations like ISHM. And then lastly is what are the steps that we need to take to protect ourselves? And there's a lot of controversy in this area, especially in the world of SPD, so we'll go through that in today's program. But to get down to a more granular level, I actually want to talk about my objectives for us today that are a little bit less formal. Number one, you need to be safe. Your family needs to be safe. And so hopefully you'll leave with some tips and tricks to keep yourself safe. Number two is that we're going to have infected patients for the next duration of time. I fully anticipate, based on CDC estimates as well as WHO estimates, that we'll continue to see sort of ebbs and flows of this virus, and we want to make sure that we're taking care of these patients in the absolute right environment. So, for example, is an ambulatory surgery setting the best place to care for these patients? Number three is we want to make sure that our patients are safe. The patients that you may never physically touch, but the patients that you're responsible for reprocessing these instruments and devices for. I can't think of a department that is more important right now in this fight than SPD, environmental services, infection prevention and control, and some of the unsung heroes throughout healthcare. And then lastly, probably my most passionate objective here is to make sure that we're actually making good, realistic decisions that are based in science, not based in fear. And I think this is one of the areas where we've seen so much misinformation out there in the media that we want to get down to a level of what is true and what is not. I would be remiss if I didn't say thank you to each of you that are dialing in today. Thank you to your colleagues, your coworkers, your leadership, your teams that you collaborate with for the work that you do. I certainly recognize that in many instances, central sterile processing and other colleagues like us are not actually thanked enough, and so I want to take a moment to recognize you. I'd also like to formally recognize any nursing colleagues that we have on the phone for Nurses Week and Nurses Day for the work that they do in protecting the patients that they serve. So let's get right into the meat and potatoes. And this slide on purpose looks a little bit busy because it shows sort of the relevance of the clinical environment in which we're functioning. So when you think about coronavirus, which causes COVID-19 infection, there are multiple different possible reservoirs or areas where this stuff can live. And we're not just talking about viruses, but we're also talking about bacteria. And specifically, we want to think about what are some of the areas of risk recognition that we can sort of mitigate. And we'll talk a little bit later in the program about different strategies to do that. Right now, for example, there is so much emphasis on PPE. And in reality, PPE is really the last line of protection, and so it's probably not the most appropriate place for us to put all of our eggs in that one basket. But we also want to look at things like biofilms, pathogenic fungal organisms. What about if the patient has any type of indwelling line? How are we going to handle the instruments after that? What do we need to do to dry the instruments, as an example? So these are all things that we have to think about. I wanted to start at the federal level and sort of talk about what's being done today and then what I likely predict will happen in the next 6 months. And if you've watched the news, you've seen that this is an evolving topic on literally an hourly basis. But specifically the federal agencies, so I'm referring to organizations like FEMA, CDC, OSHA, certainly the FDA is very involved in this. They are all charged with looking at the overall big picture from a federal landscape. So certainly their number one goal is to stop the transmission, to stop the spread of the pandemic. And that's being done through a multitude of different ways, both short-term, medium-term, and long-term ways. We also recognize that there's a huge challenge right now with even getting PPE. And there's also an underground market of PPE, which is quite concerning to me. And so many of you may have experienced this firsthand. I know for myself, in one of the clinical settings that I work in, the PPE that was provided was counterfeit. And it was not fully functional. And so this is really, really difficult to the point where large manufacturers like 3M have actually put out specific things that you should look for to actually determine if the equipment is real and authentic. So it's a very, very different world that we're living in today. The other piece to look at is things like OSHA, where they're protecting us as the healthcare workers, right? We want to make sure that there is good guidance on what to do, when to do it, and how to do it. And most of that is coming from CDC. And there's a lot of controversy about the sort of federal response from CDC. And that's for a lot of different reasons, some political, some scientific, some response-related. It really doesn't matter. But with any circumstance like what we're experiencing now, this is unprecedented. And when I look at Ebola, MERS, SARS, the novel bird flu, all those types of things, there were always sort of hiccups. And that's to be expected. And so we as a healthcare system have a huge lesson to learn here, which is we need to be self-sufficient. We need to be hardwiring good infection control practices so that when guidance comes out from organizations like CDC, we're very readily able to implement that to protect ourselves as well as the patients that we serve. If you've not seen the Johns Hopkins Corona Map, is what I like to refer to it as, it's an excellent tool to look at both real-time and actually drill down into the data at a global level. So on the left side of the screen, you'll notice that this was actually run yesterday, right before midnight. So I was trying to give the most accurate information, and there's a total of, approaching 4 million cases. And globally, there's almost 300,000 deaths. If we actually go to the next slide, you're going to see it drilled down into the United States data. And this is actually most pertinent. You'll see that there's sort of a topographic map there that actually shows down to even the county level as to where some of these things are taking place. I also tell you that there's a new tool that was added on the CDC website that even looks at social outings and sort of the impact on coronavirus spread. And so there are lots of different tools that are out there that will help us sort of manage what we're doing. So let's take our healthcare hat off and put our consumer hat on. All of us have to get groceries. All of us may have to seek some type of medical care if there's an emergency. We're going to hopefully resume going to the dentist. There's going to be a lot of different things that we'll do outside of our traditional work environment. And that clinical presentation of coronavirus presents very similar to other things. So luckily right now we're entering summer, and most of the traditional respiratory things like influenza and things of that nature are fall and winter viruses, but fever, cough, shortness of breath were the original set of symptoms that were most prevalent. If you've watched anything on the news and some of the latest studies that NIH has released, some patients, up to 25 to in some cases 50% of samples analyzed, have been asymptomatic, so they don't have symptoms. So what does that mean for us in the SPD setting? Well, that means that we need to treat all of our instruments as if they're contaminated, just like we always do. We want to make sure that we're looking at hardwiring our sort of PPE practices. We also want to institute screening for ourselves to make sure that we're not bringing this stuff to work if we're symptomatic. And then if you look at the other symptoms that CDC's added, like muscle aches or loss of taste or smell, these can be very difficult to diagnose in that overall differential diagnosis. And so the incubation time period is roughly 2 to 14 days, with the average being about 4 to 5 days. So when you see the slide that we'll have at the end of today's program about exclusion from work, this is why that 14 days is really important. And also controlling our risk is very important. Just yesterday, I had a patient, I had multiple corona patients back to back, unfortunately, and, it's very difficult for some of these patients to wear a mask. So if you're entering any type of procedural area, taking instruments back, maybe you're working as a bedside tech, make sure that you have good source control, meaning that you have some mask on yourself as well as the patient, and you'll see why that's going to be important here in a little while. I also want to go down to sort of the facts about the fatality of this. This has been one thing that's been extremely over-exaggerated in the news media, and I certainly want to talk about both the facts as well as the precipitating factors that can make patients more vulnerable. The average case fatality is roughly between 0.5 and 0.9% as estimated in the latest studies. And, of course, this will continue to change as we get more patients that test positive, we see more hospitalizations, and unfortunately we will continue to see more deaths. Patients that have comorbidities are certainly at the highest risk factor profile of this. If you looked at the data coming from New York City, for example, out of the sample that they analyzed, about 90% of those that had hospitalizations had some type of chronic medical illness. But keep in mind that many of us may also have chronic medical illnesses. And so this is a conversation that is not just about the patients that you have in your facilities, but it's also about us and making sure we stay safe. So if you're receiving some type of immune therapy where you're suppressing your immune system, maybe you're an oncology patient on the side as well, these are things that we need to actively think about to protect ourselves and our coworkers. So patients that have diabetes, certainly things like COPD where they have lung diseases, these are all things that we have to be very considerate of. Most of the hospitalizations are coming from patients that do have these other medical conditions. And a condition called ARDS, which is acute respiratory distress syndrome, it's a very fancy term of saying your lungs are failing in a big way. And most of the patients that are hospitalized are seeing this type of condition, which of course can require the use of ventilator support. When we think about this procedurally for the area that you work in, bronchoscopy is an area of high risk here. Most procedures that are going to be done with the use of a bronch are going to potentially produce aerosols, and we'll talk about why that's important here in a minute. But there's also other invasive procedures where instruments might be used. So we need to know that the patient hopefully has been screened. If they're positive, this virus is very easy to inactivate, which is good from a microbe standpoint. But we do want to make sure that we take the necessary steps to protect ourselves anytime we're handling, transporting, cleaning, sterilizing, storing these instruments. And we'll go through an example of that here at the end of the program. Now, probably one of the top questions I'm asked is, can I get tested? I'm worried. I'm a healthcare provider. My family. What do I need to do? And there is real-time testing available. There's multiple different options available depending upon where you live. Some tests come back in 30 to 45 minutes. Some tests can take several days. And so it's important that you become tested if you are symptomatic for sure. There's really not a core recommendation to test asymptomatic people. But certainly if you have an exposure, you become symptomatic, then you would automatically qualify for testing. One of the big debacles with this was sort of the widespread non-availability of this test originally. And as you can imagine, when you're developing new tests that require FDA approval, there is a lengthy process that takes place there. And so that started at the federal level with CDC, then the state health labs could do it, and now you're actually seeing private laboratories like Quest and LabCorp that are able to do this test. I believe LabCorp, for example, actually just launched an at-home test where you can do this at home and send it in. But most hospitals are not testing asymptomatic healthcare workers, and there's good reason for that. These patients are primarily going to transport the virus to us via respiratory droplets and secretions, right? So think about the instruments that you're responsible for handling, especially things like a bronch, any type of intubation equipment. If you're dealing with anything with a ventilator, these are all high-risk items. As we sort of, again, put our consumer hat back on, think about the next time you go to the dentist and you look up in the air and you see all those droplets that are there. These are things that we now have to think about that we should have always thought about, just to be clear. But we want to make sure that we're protecting ourselves as patients and receivers of healthcare, but also that our healthcare workers are taking the necessary steps to do that. And this is really where that whole 6 feet came from. And it's not an end-all, be-all rule, but it is sort of the best practice to socially distance while we have ongoing community transmission. And other body fluids can potentially contaminate our mucosal membranes like our eyes, nose, and mouth, and that's why PPE with eye protection is really important here. There's also been some other interesting developments. So let's switch gears and go from things like a bronch to things like a flexible endoscope that are used in the GI system. We have seen fecal shedding, and as a matter of fact, there's been limited data that's come out, some of which is not even published yet, that has seen that asymptomatic carriage, meaning people have no symptoms about 50% of the time. And so the symptom screening, the temperature checks, the things that your facilities may already be doing are not going to catch these people. And so, again, we want to make sure we take the necessary precautions to always practice good infection control practices like hand hygiene, staying home if we're sick, all those types of things, because we are going to see this sort of evidence of what we call super shedders. And a super shedder is essentially someone with such a high viral count that the devices, the instruments, the surfaces that they come in contact with will have extremely high viral counts. And so this makes transmission much more likely. It can even actually contaminate laboratory testing, and if that gives you an idea of what we're trying to deal with. So again, protection of our mucosal membranes is going to be very, very helpful here. The risk of transmission is something that's been discussed pretty heavily. There are, evidence, as we've talked about before, that people without symptoms can transmit, meaning that you very well may have instruments and devices coming through your departments that you have no idea the patient's COVID positive, just like you may never know someone's HIV positive. And at the end of the day, it really doesn't matter because the good regular practices that you're doing are going to protect you with a few slight enhancements of things like PPE if you're going to be producing aerosols. Community transmission is a huge deal right now. We continue to see people not abiding by social distancing, and certainly I want to be, reflective of the impact economically, especially that these orders have had across the country. I've got several friends that own small businesses that are in danger of going bankrupt from this. And so it's a very careful balance that the government has between sort of the civility of our civilization and our economy versus public health practices. And so this is why things like understanding how the virus is transmitted is going to be very helpful for us. We'll talk a little bit later about environmental transmission of the clinical environment of care outside of devices because we recognize that there are many surfaces that we come in contact with on a daily and hourly basis that might be contaminated as well. From a community spread standpoint, it's pretty much everywhere. We do see some pockets where there's not a lot of community transmission, and that's great. And this is really what led the CDC to come up with the face coverings idea, right? Because that face coverings idea is really to protect your droplets from going to other people. And so the thought is if everybody's wearing some type of face covering, if you cough or sneeze, a good majority of that hopefully will be dispelled down to the ground versus out into the air. But also remember that these face coverings that are homemade have no efficacy, no clinical data to support their use. And so it's really a sort of public health practice when widespread availability of proper PPE is not available. And so in the healthcare setting, we always need to be using proper PPE. We talked a little bit earlier about vulnerable populations, but I know some people have a question of specifically, what if I have one of these conditions and I'm working in the SPD department or I'm working in the hospital or I'm working in the ASC environment? What do I do? Well, you could certainly have that conversation with your supervisor. There are some people that I would frankly recommend not do reprocessing of instruments right now. So, for example, if you're actively ongoing some type of oncology treatment for ongoing cancer, you are certainly at very high risk. People that have chronic respiratory diseases are at high risk. And so it's certainly worth a conversation with your employee health department to say, is this probably the best setting for me to be working in right now, or is there some type of protective respiratory equipment that I can get? And we'll talk a little bit about N95s versus other things as well. And the comment here about children and pregnant women are not being near as impacted is evolving. We are seeing more and more kids test positive. Luckily, they're not near as sick as the adult population. But since there's been very little widespread testing of the pediatric world, we really don't know what the carriage is. So for those of you that are parents or around kids on a daily basis, keep this in mind. And we've also seen that the majority of healthcare workers that have become infected have actually not been properly putting on or removing their PPE appropriately. Or they weren't, frankly, given the proper PPE in the first place. And so this is an unfortunate situation that brings us to sort of where we are today. Now, I'm a big believer in life in choices. I think you can either react to life or you can actually drive your life. And I try my damnedest to actually be proactive in what I do. I try to look ahead. Try to look forward. I try to think strategically. And I think many of us would love to be there. But we also need to be real and say that in many instances, we are not able to actually do that. And that's sort of driven by our approach that we get from, our workplace, our supervisor, lots of different things. So in the infectious disease world, we can either prevent the microorganism or the contamination in the first place, which is the absolute best place for us to be, or we can be where many healthcare facilities are, where they're preventing transmission and actually trying to recognize the presence of that outbreak. So how does this translate to things like instruments? Well, if I can prevent the contamination in the first place by making sure my instruments are properly maintained, they're properly cleaned at the bedside, they are properly disinfected, they're properly stored, then this is going to help prevent contamination. Another one that came up very frequently in a lot of work that I did with endoscopes was ensuring that the endoscopes were dry. Or the bronch was dry or the instruments were dry, because we recognize that especially in dark tubes like endoscopes, if moisture is behind there and it's not expelled, it's going to potentially grow organism. And there's been lots of data that suggests this. And so instrument storage is a huge element of how we're going to prevent potential transmission. So there's a couple core approaches that CDC's outlined, eight total, that we're going to quickly go through here today, that help us get to a sort of future-thinking state to prepare not just for COVID-19 pandemic, but what would we do in an outbreak or pandemic of the future? So the first thing that we can do is we can minimize the potential chance for exposures. So if we can put in place an engineering control, we can make sure that we have PPE. These are all things that will help us minimize the chance for exposures. Another thing that you're seeing most hospitals especially do is not allow visitors. And this is not just true for hospitals, but also for long-term care. The other day when I was driving home from the hospital, I saw one of the most amazing yet sad things I think I've seen in my career. And I had my window down because, as you can imagine, when you've worn a mask for 12 to 16 hours a day, you want fresh air. And I hear the voice of an older man singing. And I can see his head in the bush over to the left, which is where there was a long-term care facility. And he just had this amazing voice, and he had his hand on the window with a flashlight. And I couldn't help myself, and so I turned over there, and I looked, and he was singing to his wife, who was a long-term care resident, because they didn't allow visitors. And, this is something that it should move every single one of us. It should remind us of why we do the respective roles that we do. And it should also get us up in the morning to help us be reminded of really our purpose. When we can make sure that our patients are safe, our coworkers are safe, our instruments are safe, and we can deliver life-saving clinical care, it's a great place to be in healthcare. The second thing that we're going to talk about is PPE, making sure that we're following the standard enhanced precautions for this. And specifically, I want to call out the use of eye protection, and I'll give a few recommendations based on my personal preferences here in a second. The other thing is minimizing sort of the flow within the facility. So don't have multiple people come in through your environment if you can help it. This is why controlled door access is really important, I think. Controlled access to instruments is another one. making sure that you can control those is huge. Engineering controls is number 4, and that's really where we can actually engineer out risks. So PPE is at the very bottom of that sort of pyramid, whereas engineering controls are really going to be very effective at hardwiring our best practices. The next one is tough. When we think about, especially today with the economy and people being furloughed, healthcare workers in particular are absolutely living paycheck to paycheck. And rightfully so, given the current economic state. And so if you are sick or ill, even if it's not coronavirus, many healthcare workers still report to work because they simply don't have another choice financially. And so the solution to that is for healthcare leadership and executives to put in place solutions that reward providers, should I say, to stay home if they're ill. And that way we can protect our patients. And this is really difficult for especially hospitals to get behind because they think of, liability and cost and people who abuse the system. And the answer to all of those is that's absolutely a possibility. But it's a bigger possibility for liability if we really encourage and allow healthcare workers that are actively sick with infectious illnesses to come to work. If you have a fever, diarrhea, vomiting, or an unexplained rash, I don't want you anywhere near me. Until we figure out what it is. And so we need to make sure our human resources department are behind this. If you're in a management or leadership role, this is really important that we do this now so that we don't have this continued problem in the future. And the last couple ones are something that we should be doing, but we need to do a different way. So, for example, we spend a fortune in healthcare on training, but we spend very little on actually managing competencies. For those of you that are certified in any of your specialties or areas, you understand what I'm talking about here. You have been deemed competent based on the cognitive competencies for that specific board certification. And so for that, congratulations. But how do we take competency to every single person that's role specific? And then the last two are really looking at the general clinical environment of care, which we'll talk about disinfection, and also working with public health authorities to ensure that we're actually reporting these illnesses correctly and efficiently. So let's start with ourselves. Well, we need to be careful. We need to make sure those around us are careful, and that starts with screening. It is well beyond just looking for the presence of a fever or just symptoms. We also want to ask them, have you been traveling? Where have you been? Have you been outside your local community? Have you been exposed to someone with confirmed or under investigation for COVID-19 infection? These are all things that, and I was just at the hospital the other day, and I was unfortunately very alarmed because I walked in and there's a huge sign that says all personnel must be screened. And, there was no universal screening taking place. And in addition to that, when there was screening, the only thing that was done was taking a temperature with a tympanic thermometer. No questions were asked, no survey was conducted. And then another facility I went to later that week, there was a gentleman at the emergency room door, and he was asking questions. And unfortunately, when you answered yes to any of those questions, they still let you in without any additional questions. So we need to make sure that what we're doing makes sense. We also want to ensure that staff members have, A, the appropriate PPE, B, they've been fit tested for the PPE, especially respirators, and C, they know how to do it. So this should be a visual competency where the specific PPE that you have, you should once a year make sure people know how to place it on correctly, to don it, and then how to doff it and take it off. The other thing we can do is look at workplace illness monitoring as well as temperature checks on every single shift. So let's get down into what the current recommendations are for PPE. And again, this is a very hot topic, as you can imagine, for certain reasons, and we'll try to go through those. But we're certainly going to wear our general precaution type PPE. So we're going to have, an isolation gown, a coveralls is acceptable. I personally like a coverall if I'm going to be in a specific environment. So if I'm going to be, for example, in the ICU for the whole day, or I'm going to transport a patient into a hospital, for example, then a coverall is really good to use for that. It certainly can be used in the SPD setting as well, or an isolation gown. Gloves are recommended. Many times I get asked, should I wear 2 or 3 pairs of gloves? And the answer is no. We only did the double gloving for Ebola based on the body secretions and the risk, but that's not currently a CDC recommendation. If you have an accessible, a NIOSH-approved particulate respirator like an N95, is going to give you the ultimate level of protection here. Some facilities have also issued certain departments PAPRs, which is a purifying apparatus that looks similar to like a hood, and it's got a hose. You may have seen it on the news. Those are very comfortable. That's actually what I prefer if I'm going to be in a setting like this. And they have battery packs that some of them, I believe, last up to 10 hours. Another one that is commonly sort of applied, if you will, is eye protection. You know, anytime you have a patient that has droplets or anything in the air, we want to make sure if there's going to be any type of secretion floating around or potentially hitting our mucosal membranes, it's not good enough just to actually cover the mouth and the nose. We also want to cover the eyes. And so that eye protection is really helpful here. Personally, for me, I love a face shield. I feel like it gives me a little bit more ventilation. I wear the mask underneath that, and it works very well for me, and I can disinfect that face shield. I've even got a reusable one as well. And the amount of time that COVID-19 and the coronavirus itself stays in the air is estimated a little bit less than 3 hours is some of the data that's been out there. And so what does this mean? Well, this means that we need to make sure we have good, adequate airflow, circulation, turnover, that we are provided respirator protection if we're going to do anything that'll generate aerosols. And that's been a question that's come up quite frequently is, do I need to use a respirator for every single procedure? And the answer is no, you don't. The CDC recommendation is a respirator for anything that will generate aerosols. On that web link that's down there on the bottom of the slide, you can actually see a listing of what CDC has automatically said are potential aerosol-generating procedures. That is not an all-inclusive list, but it does give you a good idea of the types of procedures that we should be most concerned with. With respiratory protection, if you are wearing a respirator, you do need to be fit tested. This is an OSHA requirement. OSHA did put out a sort of temporary waiver given what was going on, but it doesn't negate the fact that this fit testing is very, very important. And then you have your user still test once you put the mask on to ensure that it's properly fitting as well. Certainly these respirators, especially the N95 type, were never designed to be reused, but we're now in that circumstance. And so all of this is regulated under the OSHA Protection Act for respiratory protection. And so if you're using anything that's being reused, we want to make sure that it's properly cleaned and disinfected. And if possible, some of these things can actually be sterilized. There is new respirator reprocessing guidance out from CDC. So, hopefully each of you that are working actively in the SPD setting have been involved in this. If your facility is doing this, most likely you're actually doing the work. And so there is evolving guidance that comes out on a weekly basis about certain manufacturers, preferred techniques. Many of the manufacturers have actually released their own guidance and testing based on this. But again, this is for a critical shortage situation. The new normal should never be that we're going to just reprocess these devices on a regular basis that are designed to be disposable. I can tell you, having used these masks after they've gone through multiple different modalities such as vaporized hydrogen peroxide, I've seen sterilization, you name it, many of these masks very quickly break down after several uses. And so it's extremely important that we are protecting ourselves and checking the integrity of these masks before we apply them and use them in any type of setting. CDC did put out this graphic that helps us remind ourselves of the differences between that traditional surgical mask and that N95 respirator. And really the big thing I'd like to point out here is that surgical mask is going to help us with those big droplets, right? The things that are going to primarily fall to the floor. So when you think about regular flu, we always recommend droplet precautions because the droplet particle size is so large that it actually falls to the ground. And so when we have novel viruses like coronavirus, specifically this version, we have to make sure we take extra steps when needed, especially when aerosols are going to be in the air. And that's why that recommendation for a respirator mask was made. These masks are regulated by the FDA. So I mentioned earlier that the guidance of them, the sort of physical use and protection mechanisms are regulated through OSHA to protect us, but the physical device itself is actually regulated through the FDA. One caveat here is please, 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 if you're receiving mask, make sure that it is one that is on the FDA's approved list. You can simply go to fda.gov. On the home page, there's a coronavirus tab. You can download that list. I've seen it updated sometimes several times a week, and it does have a listing of masks that are deemed effective, if you will, and sort of acceptable for emergency use right now. If it's not on that list, I would strongly recommend against you using that in a healthcare setting because it can provide you completely unprotection to say the least, and you may not have any efficacy data supporting that. So again, these are sort of what I refer to as the imposter mask, and many of these are actually made in China. I've seen lots of these come in that have been seized by Customs and Border Protection for good reason. Transitioning to eye protection, again, my recommendation and sort of personal preference is the shield because it gives you that total eye protection. Goggles are acceptable as well. We see a lot of exposures just in general, not just with COVID, but people that are wearing just regular eyeglasses or glasses that they think are safety glasses without the wraparound on the side. So the goal here, according to OSHA, is to protect the entire sort of ocular area. So we want to make sure that we're covering both the front, the top, the side, and the bottom of the eyes when we can. And so, again, if you're doing anything where there's potential splashing, droplets, COVID, those types of stuff, we want to make sure that you're going to do eye protection as well. So let's talk about the sort of elephant in the room, which is what we refer to as aerosol-generating procedures. So, again, there are a listing of sort of examples, not an all-exclusive list, but there is a listing on the CDC website. But certainly things where if you're nebulizing a patient, if you're doing CPR is another common example, ventilating a patient, bronchoscopy is another example where you may have aerosols. If the patient's on a ventilator, you may have aerosols, those types of stuff. This is where a respirator mask is strongly, strongly recommended. As a matter of fact, CDC goes as far to say if you have a shortage of these types of masks, it should be reserved for people that are going to be exposed to aerosol-generating procedures. So, for example, if you have an instrument that you're reprocessing, and as part of the normal reprocessing of that device, it produces aerosols as part of the cleaning or reprocessing, then you would need to wear an N95 respirator mask. That is not to be, said that that's going to be the norm. Certainly, hopefully, most manufacturers have figured out a way to decontaminate the device and disinfect and reprocess it without production of aerosols. But this is something that you should be aware of and be afforded the opportunity to wear a respirator if needed. Now, there are many hospitals that are issuing all clinical providers respirator mask, and that certainly is fine as well. It may be difficult with supply chain shortages. But I think one of the big future thinking sort of topics with this area is to get away from these disposable respirators and look at what some other places, there's an infectious disease hospital, for example, in the U.S., there's several overseas, and they actually issue every employee at the time of hire a half-face respirator that can be reused multiple times and the cartridges are changed. It is certainly a little bit more bulky, but honestly, I actually find them more comfortable. I find it easier to breathe in. They can easily be wiped down with a regular disinfectant wipe, so they don't have to undergo any type of special reprocessing. And then, like I said, the cartridges can be changed. And so this is something that when we look at how do we emerge from this and move forward, I think that's a very strong thing for healthcare providers to think about, is to invest in those types of masks where we don't become reliant upon disposable products that are not even made here in the U.S. There's a couple new tools that I wanted to share with you. There are tools being added every single day on the CDC website, and I've tried to give you the download links here as well. But this one is really important. This is the new PPE burn rate calculator. So this is a tool that is in Excel. It is designed to allow you to predict for your department. So if you know you have, let's say, 15 techs and you do so many procedures and your hours of operation are X, Y, and Z, then you can import this information and you can actually give your materials management a real-time prediction based on the need that you will have per PPE. This is also something that a hospital should turn around and aggregate by every department and give to their medical surgical distributor so that you're going to accurately forecast your PPE needs. Now, that's for today. Let's talk about the future. There are lots of companies, which is amazing and exciting to see across the U.S., that have stepped up to the plate and said, we're going to help. Some of them, their hand was forced, others volunteered, and it doesn't really matter. The fact that we are producing PPE in multiple different places in very unconventional settings, like GE producing ventilators as an example, allows us and affords us an opportunity to get prepared for the next wave of this or whatever else it may be. When I look back in my career, it's almost like every 3 to 5 years we have something major. And so it is very likely that we will have continued transmission of coronavirus. We're then going to have the fall and winter seasons where our regular things like influenza and our other respiratory pathogens are coming into play. So this is not something that we can just put on the shelf and say we're not going to do this anymore once Corona goes away. It's really a wake-up call to us to say, how do we protect ourselves? How do we protect our teams? How do we care for the devices and instruments that we're responsible for? And specifically, how do we have the best possible data? I want to transition for a second into medical device reprocessing. The coronavirus, as I mentioned before, is not something that's new in general. This particular strain is new, which is hence why it's called novel, but it's very easy to inactivate. So basic disinfection, certainly sterilization, HLD, all of these things are going to be very effectively able to inactivate this. But we also want to look at our HLD to ensure that it has the right claims. And this should be something that's regulated through the FDA. And so if you're using an FDA-regulated product, this has already been done for you. And there's also evolving and emerging guidance coming out from different clinical societies recommending single-use devices in some settings for coronavirus patients. And so this is out of an abundance of caution to say, let's not even reprocess that. Let's just get rid of it. And so we'll probably see more and more societies that will come out with those types of recommendations. Back in 2015, the FDA came out with a listing of what they call design challenges associated with medical devices. This was frankly driven from initial sort of observations about infections related to endoscopes. But if you look at the list, it really applies to many of the devices that we handle, like surgical instruments, certainly devices that have O-rings. And the point in sharing this is that there are so many places where these particular viruses and bacteria and fungal organisms can live on medical devices. And if we don't have good validation that our cleaning processes work, we're really sort of dead in the water. And keep in mind that I've already said this virus is very easily killed, but it can only be killed if it's exposed to the disinfectant or the sterilization process. So it's important that we clean and decontaminate these devices thoroughly. We also want to look at, can we clean it? Is it accessible, and how similar is it to other things? These are all things that will help us evaluate contamination potential. And there's a great new science called human factors that has been taken from other areas. So it's really more new to medical device world and less new to general society. We've seen this used in other places like manufacturing, certainly the aviation industry, and it's really been nicely applied to the medical device space to say, can a user with the proper training reprocess said device in a consistent way just like any other person if they've had adequate training? And so when we think about the whole COVID thing, it's an opportunity to say, are we properly trained in role-specific competency, and can other users follow the instructions for use from the manufacturer? And so many manufacturers are now being required by FDA to do human factors testing for their device, either at the time of clearance or even post-market. And so this is a question you should ask your device suppliers, have you done any type of human factors validation? Because that's going to tell you where the potential failure points are so that you can mitigate that risk. And when we look at general reprocessing, the FDA said it needs to reflect the intended use. So how are we going to use it? Where are we going to use it? What process do we need to clean it, right? What is it going to be? HLD, sterilization, low-level disinfection? Is it going to be a throwaway, disposable device? And then I find these last three kind of interesting. It needs to be technically feasible, so the reprocessing instructions have to be technically feasible, but they also have to be comprehensive, but they should be understandable. Well, I don't know about you, but if I look at a reprocessing manual and it's 100 pages long, I don't really think that's going to be very understandable, and I don't know how likely someone's going to be able to translate all 300 steps into action. And so this is a conversation we need to be having with our vendors to say, what can we do to shorten reprocessing? How can we mitigate that out? Are there human activities that can be removed from the equation so that we can mitigate this risk? Critical items, are the easiest here because sterilization is going to take care of this with no problem at all. But we do want to make sure those instruments are properly decontaminated, that we're handling them correctly with appropriate PPE. But there's really nothing special that you have to do if your product's going to be undergoing sterilization. Now, when we look at semi-critical items like your endoscope blades, your endoscopes, things like that, one of the big risks that I think is here is drying. We want to make sure that if something is reusable, totally different conversation if it's disposable because the risk is thrown away. But if you're using anything that's reusable, especially things like endoscopes, you need to make sure that it's completely dry. So what I see all too often, especially in sort of the GI labs, is they'll have underpads or chucks underneath the endoscopes in the drying cabinet. And this to me is a big red flag, because why do you need that there if your instrument is totally dry? A particular concern, I've seen several hospitals, and I have a very sensitive sniffer, if you will, to black mold. And I walked in units, and we're able to smell black mold instantaneously. And upon inspection, I found, water has sort of, pooled at the bottom of these cabinets. And so it's not only a good idea to make sure that the instrument is dry, but if you have the capability of using something like a drying cabinet, especially one where the temperature and humidity is controlled and there's a forced air dry, that's going to be even more powerful to making sure that these instruments are not recontaminated after the reprocessing process. And lastly, one thing that's come up a lot is, should we culture for coronavirus? And there is no recommendation at all to do that. And viral cultures can be pretty problematic to collect and grow. So the traditional culture methods that exist out there from FDA for medical devices are really related to bacterial cultures, not viral cultures. So when we look at the general continuum of care, right, we're sort of at a point where we've got reprocessing technicians, we've got nurses, we might have physicians, we've got SPD, and we've got all of these different places where various parts can take place. So, for example, if you have a bedside clean done by a nurse or a tech up in a unit, and then that device is couriered down to you and it's not covered, as an example, or there's a spill in the hallway. These are all things that we have to think about. As more healthcare facilities are going to centralize central sterile processing, this can become problematic with couriers that are driving vehicles where you've got instruments in there. What happens if they're in an accident, for example? Has that courier received bloodborne pathogens training? Do they have any type of PPE in the vehicle should there be a spill? All the way up through how are these devices stored and maintained? If I've got a scope, for example, hanging that's been there for a year, and I'm the patient, I really don't want that scope used on me. I want it to be cleaned a little bit cleaner before it's used after it's not been used for a year. And so think also about specialty instruments where there may be contamination that exists there as well. And then lastly, let's look at sort of the lowest level here, which is your environmental infection control recommendations. So now we're talking about our non-critical items as defined in the Spalding classification. And we're really thinking about the stuff that we're touching. So blood pressure cuffs, pulse oximeters, environmental surfaces, countertops, sinks, maybe a piece of equipment you have on the countertop. These are all things that we have to think about. Computer keyboards is another big one. And the good news here is that most disinfectants are going to, again, readily inactivate coronavirus. And these types of disinfectants, the ones that comes in wipes, sprays, or liquids that are used on environmental surfaces, unlike your HLD and your sterilants, are regulated by EPA. So again, your sterilants, your HLD, that's all FDA land, but we're talking now about stuff that's regulated by the Environmental Protection Agency. And you're not going to see COVID-19 or coronavirus, specifically this novel form, on these product labels. You will see some products have actually specifically tested for coronaviruses, and therefore they are actually on the EPA's list. There's other products that have not specifically tested, but based on the other claims that they have been deemed effective, and there's several manufacturers that are actually testing this particular strain, which again is not necessary, but it certainly is a step in the right direction. And so you can look at that EPA listing, which is on EPA.gov, as well as the CDC website that I've listed there below. And it is May, which is Hand Hygiene Month, and I sort of had mixed emotions about that, to be honest, because I think every day should be Hand Hygiene Day. And so when I get to May, I sort of cringe a little bit because it's difficult to recognize hand hygiene is important only in 1 month, when in reality it should be one of the most hardwired infection control practices we have in general. And so again, alcohol-based hand rubs are very, very effective if you can find one. Soap and water is also effective here. And there are, people that are out there marketing products that say that they kill coronavirus. FDA does not allow those types of claims. So if you see somebody doing that, chances are, you're getting lied to, unfortunately. But your general alcohol-based hand rubs are completely fine. I did want to remind us of the proper steps to, don and doff PPE. These are listed here. I've also included a listing, a web link down there where it specifically shows the actual pictorial version. This is a poster I would strongly recommend that you actually place in your units and in your workplace. Put it in the break room, put it in the clinical areas, laminate it, mount it, whatever you need to do. But I'm a pictorial guy. I like to see it, and then I like to do it. If I have to read it, it's very difficult for me. But what we're thinking about here is we're going to, take off from the dirtiest. So starting with gloves. And so again, there's different ways to do this depending upon the type of PPE that you're using. On the CDC website, you'll also find customizable videos that allow you to get down to the level of granularity of saying, this is the type of mask I use, this is the type of eye protection, and it will actually generate you a custom video. That was all developed, ironically, through the Ebola training grant that CDC awarded to Johns Hopkins, and they did a phenomenal job on creating these tools. And then there's some other things that we could think about, not just in our clinical areas and our reprocessing areas, but also in our general workplace, like no-touch receptacles, making sure that our facilities are offering face masks to visitors if they absolutely have to come in, making sure that hand hygiene is everywhere. But sort of a little caveat with that is we do have hand hygiene pretty much everywhere in healthcare, and yet our national compliance looks, sort of looms around 40%. So 60% of the time, in many instances, healthcare workers are not sanitizing their hands despite it being readily available. And if you can, and this is not a current CDC recommendation, but something to consider, look at having a dedicated staff person for reprocessing of these instruments that are COVID contaminated. So that's another practice that you can look at. What we don't want to do is have all of our workers exposed unnecessarily or without notice. And they're not wearing proper PPE. So if you're able to, this is something that you might want to consider, as well as things like staggering your workforce so that you're not having the entire team there the entire day, but you're really staggering those shifts. That's another thing that we could think about. CDC has published some guidance related to air exchanges and transmission of organism. Well, this is huge because if you're in an area where the humidity is high, you're reprocessing, you've got water, you've got potential aerosolization, you want to make sure that you have adequate air exchanges in order to clear any potential contaminants from the atmosphere. So the best advice I can give you here is to work with your building engineers, anybody that, if you're in an outpatient setting, certainly the landlord might be able to assist you with this, but know what air exchanges you have per hour, and that might need to be adjusted. Another potential solution is to have something like a portable HEPA filtration system, which we're seeing lots of hospitals do, especially in the ERs, where they don't have enough negative pressure rooms, and essentially they're creating them using this tool. And then let's look at engineering controls, which is really my favorite because it hardwires the risk. It sort of removes it, if you will, by creating some type of barrier. So it could be something like a physical barrier. If you've been to your local grocery store lately, I know I'm here in Atlanta and we have Publix as well as Kroger. I know Publix has installed plexiglass right in front of the cashier. I had to go to the postal office the other day to drop something off, and I was shocked to see that they had plexiglass now there as well. But I saw very little hand hygiene. And so, a physical sort of engineering control is good, but we don't ever want it to take the place of our basic infection control mechanisms. We could also look at negative pressure rooms as well, and this may change based on where procedures are being performed. And so if you're not familiar, the Center for Medicare and Medicaid Services issued guidance and originally in this that essentially allowed healthcare facilities, specifically hospitals, to use ambulatory surgery centers if needed. Luckily, we didn't get to that point, but that is potentially an occupational risk because those settings are not always set up the way that we would want. And so there may be instrument contamination issues with there. There could be respiratory contamination. Certainly patient cohorting is very difficult in those settings. So again, we want to make sure that where we're doing the case or the procedure is the ideal place. So I mentioned earlier that there was sort of this hierarchy of controls, and that PPE was at the very bottom of that pyramid. And so here's sort of an example that helps us understand where we should start and then where we sort of currently are. So if we look at today, where we are with coronavirus and COVID-19 infection, there's so much emphasis on PPE. Get more, we need more, we have to have more, everybody needs this, everybody needs that. In reality, PPE is, again, that last line of defense. Whereas if we look at the top of the pyramid, where things like elimination are there, this is going to give us our best chance for hardwiring success in eliminating the risk. We could also substitute it. So, for example, I've got a good friend that's a respiratory therapist, and she called me in a panic because she's pregnant and, she's got some health conditions, and she said, should I quit my job? And I said, well, tell me why you think you should quit your job. And she said, well, I don't think that I can care for these patients and do breathing treatments and intubate and all this other stuff if they won't give me a respirator mask. And so that was an example of the sort of employer was trying to get PPE versus looking at how do we substitute that risk or eliminate that risk? Is there another role that person could temporarily take, for example, where they could still practice respiratory therapy, but maybe they were not doing it in a clinical setting, but maybe they were doing like telephone triage, or they were serving as a monitor tech or something like that they're qualified to do. You could also look at substitution where we replace the hazard. Engineering controls themselves help us isolate people from the hazard. So a perfect example, I saw this yesterday, ironically, at Walmart coming home, was they had put together an engineering control where they had taken partitions and essentially created a one-way in and a one-way out where you couldn't pass through the other side. So they're essentially trying to say everybody's looking forward, and they had somebody stopping somebody every 6 feet, and it was quite interesting to watch. It was like, sort of corralling cattle, but people did listen, and they did respect it. And so these are examples of engineering controls that will help us. And then the last piece there is administrative controls, where we actually change the way that we operate our normal processes. So a great example of this is staggering shifts so that we don't have everybody in the building at the same time. You could certainly look at making sure that you go in one door and out another as another example of sort of an administrative control that also lends into engineering. And as we sort of emerge from this, part of today's focus was to look at not just where we are today, but where do we go in the future? And I want us to really sort of ditch the word training and move to role-specific competency. So if you're an SPD technician and your responsibility is surgical instruments, you should be checked off on reprocessing of surgical instruments. If you're a GI reprocessing technician and you do endoscopes, you should be checked off on model and role-specific reprocessing there. So this is something we don't do a good job of in general. Our clinical sort of care providers, like our nurses, physicians, people like that, are very used to clinical competencies of performance, where they actually have to do the skill in front of a trained person that is an expert in that. We really need to look at doing that here so that we especially are putting on and removing our PPE appropriately, because we recognize, and I just literally had this conversation with a colleague at CDC, and the absolute biggest risk to us as healthcare workers is really not the patient. It's actually our improper use of PPE. So we can certainly put a mask on the patient, and that's going to help us, but we need to make sure that we're doing things appropriately as well. So I'd like to finish up with a couple tools and resources, as well as probably one of the biggest questions, which is, what do I do if I get exposed? This new checklist that's listed here is the new hospital preparedness checklist. It was released a little bit later last month. But it's a great tool that helps you look at it by department. It's very, very comprehensive. So I'd recommend that you download a copy of this, print it off, and do it for your department, and then work with your facility's infection preventionist in order to hardwire and ensure that you have some of the best practices out there. There is evolving guidance for treatment. This is another huge question I'm commonly asked is, what do I do if I get it? Is there anything that will help me? And remdesivir is one that's been on the news a lot in the last 24 to 72 hours based on an investigational study that came out that showed a lot of promise at decreasing length of stay and hospitalization. Certainly we've talked about hydrochloroquine and things like that. But as of right now, the FDA is going through sort of the formal review processes, and they have issued emergency exemptions. So that's something that we want to think about, is we will continue to see more therapeutic options as far as treatment. But the other thing that's going to be really long-term and specifically hopefully later this year, let's cross our fingers, is a vaccine. And so when we think about sort of the stages of this, we've got diagnosis of infection to say yes or no. We've got presence of antibodies, which is sort of a new tool now. But unfortunately, if I tell you have antibodies, it's very different than like measles, mumps, and rubella or hepatitis, where I know if you're immune or not. With this particular immunity test, I don't really know if you're immune or how long you are. So sort of that potential for reinfection is still present there. And then when we look at treatment options, this is probably the most immediate need to treat patients that are hospitalized, that have any type of comorbidity or other issue. And then long-term, like I said before, is the vaccine. I'm going to be really frank. I have grave concerns about the effectiveness of only a vaccine, and I'll tell you why. Because when we look at general sort of compliance with a recommendation like get an annual flu shot, and even in healthcare workers, I haven't looked at the latest data, but it's not as good as you might think. And so what's to make us think that if we can't get people to get a flu shot that work in healthcare, we're going to get people in healthcare to get a very new, it's not going to have a ton of data. Certainly doesn't have a long safety profile because we haven't been able to study it that long to get a corona shot. For me, I will absolutely get it. I have total confidence in the way it's being developed. Certainly is an accelerated process, but I worry about sort of stopping community transmission only based on a vaccine. Hopefully I'll be proven wrong, and that would be my goal, but that is something that we have to think about from that perspective. So I wanted to share with you as we get ready for the Q&A a couple of things that come up all the time. Number one is, what do I do if I'm exposed and I'm wearing X? So I wanted to start with the sort of best scenario, which is we have some type of protection and the patient does. So if you're interacting with the patient, this is going to be relevant. If this does not apply specifically to the instrument because you'll be wearing PPE anyways. But let's just say that you go into some type of clinical area, and let's say that you are wearing all the recommended PPE except you're wearing a regular face mask and not a respirator, and you have contact with a patient that is COVID positive and they are wearing a face mask. So if you look at the very bottom row of that, you'll actually see it says that is a low exposure and that it's self-monitoring where you're supervising and there's no restrictions from work. Versus if you have a healthcare worker, which is the second row, not wearing any type of face mask or respirator, then that's what we refer to as a medium exposure. You're going to have to actively monitor that person, and they cannot work for 14 days. So that's if, again, you have some type of protection and the patient does. Let's go to scenario number two, which is really problematic when it comes to people with no symptoms. So let's say that now the patient, the suspected patient, is not wearing a face mask. And you are, let's say, not wearing eye protection, but you're wearing everything else. That's still medium. That's still going to require you to be excluded from work for 14 days. So that's why I really stressed early in the program that it's not just about the mask. It's not just about hand hygiene. It's also about that eye protection because, again, with droplets that are going to get into wet mucosa, this is where a big risk for us is. So anytime you're wearing a mask, you need to be wearing eye protection. For me, that is my general practice. If I'm putting on a mask or if there's any respiratory secretions, coughing, sneezing, it doesn't matter, I'm always wearing eye protection. That's a practice I've had for many years. I think it's one that is sort of a lessons learned from this equation that we want to think about. And the last area that I wanted to cover, which is sort of once I get exposed, when do I get to come back to work? So let's say that I'm asymptomatic, for example. So there's sort of two different strategies that you can take according to CDC. One is the use of laboratory testing, and the other is what we call a non-test-based strategy. So I'll cover the test-based strategy first. First of all, you want to have resolution of fever and certainly symptoms without any use of a fever aid, so no Tylenol, no ibuprofen, anything like that. Improvement in respiratory symptoms, and at least 2 negative tests 24 hours apart. So again, this is based on if you have accessibility to testing. There are also a lot of people that have been exposed at the healthcare setting, and they still are working because they're not symptomatic. And so critical infrastructure like healthcare, there is guidance out there that says if the person's asymptomatic and they're wearing PPE, that you can allow them to continue to work if they're a critical employee. And so that's available on the CDC website. The second strategy is what we refer to as the non-test-based strategy. So you're going to exclude yourself from work for at least 3 days, we're talking about 72 hours, since you have recovery, and at least 7 days have passed since symptoms first appeared. So again, this is a decision if you're in a hospital that's going to be made in collaboration with your occupational health and infection prevention department. But these are the two strategies that are available out there. An antibody test alone is not going to tell you if you can come back to work, not in its current capacity, because again, we don't know what that level of quote-unquote antibody actually means. It's helpful to know if people are producing antibodies, and I think eventually we'll get down to the level of granularity of saying, yes, if your antibody levels are this, then you are fine and you're deemed immune, but we're not yet there. So what do we do as we move forward? Well, the first thing is we need to sort of prepare ourselves for continuous readiness. Very similar to Joint Commission's always referred to always be ready. We want to make sure that we are ready in whatever role that we're in. So if you're in central sterile processing, If you're in the GI lab, it doesn't really matter. If you're a clinical provider, everybody plays a role in pandemic preparedness. And it's going to go well beyond COVID-19. One of my biggest fears is that when we get into our respiratory season later this year is what happens if we have RSV, influenza, and corona all floating around at the same time, which is a very likely possibility. And many of those symptoms can mask other things. And so we may not realize that this potential flu patient is actually a coronavirus patient. We also find that many of these coronavirus patients have secondary bacterial infection. And so there's a lot of sort of balls up in the air as to how do we handle this. We want to make sure that we're screening both employees as well as patients to lower that risk. So temperature, travel history, symptomology screening. There are even places right now that I'm aware of that are testing surgical patients that are doing elective procedures. I sort of have mixed emotions about this because, if I test you on Wednesday and your surgery's Friday, it is certainly possible that you could become positive between then. So it's not going to tell us a ton other than the patient is, infected or is not. What some places are doing is they're using the rapid test and they're doing it the morning of. There are also countries right now that before you can board an airliner to fly, you actually have to get tested at the airport. And so we'll probably see some level of a sweet spot that's a sort of pragmatic approach in the middle, but we're not yet settled on that. We also want to take care of ourselves to make sure we have resiliency. Going through Ebola, certainly now this, I'll tell you, it wears on you. The use of PPE wears on you. Last night I felt like I needed to put an ice pack on my face when I got home late at night because I had literally been wearing PPE all day long and it hurts. And so you want to take a step back and say, how do I take care of myself? How do I make sure my colleagues and my community are safe? And make sure you try not to deviate from a routine. And then there's some basic things that we can do as related to basic hardwiring of infection prevention practices, like looking for potential prevention activities, keeping patients out that are sick, making sure that if we have healthcare workers that are sick, we stay home, practicing regular hand hygiene with either alcohol-based hand rub or soap and water, the appropriate use of PPE, and the availability of PPE. I want to make a statement that may be a little bit charged, but I think it's important. Never, ever, ever has a pandemic been an emergency, meaning that you do not, negate the need for PPE to handle a device or run into a patient's room simply because there is an emergency in the room. That just does not happen. There's nothing that says we have to run into the room without our own PPE. And the same is true for you in the SPD world. Your multiplying force is huge because of your specialized training, expertise, knowledge, and dedication to your field. So if we lost multiple people in the SPD world, we'd be in a very bad position to operate hospitals. I know I've got one colleague that works in a hospital right now, and they had 5 people out with coronavirus out of a team of 20. So that was 1/4 of their team that was out because they did not encourage people to stay home. And so they actually had to cancel procedures and call in extra staff. I mean, it was sort of a nightmare for them. But you want to be considerate of that. We also want to ensure that we're keeping the environment as clean and sanitary as possible on a routine basis. So thorough disinfection, cleaning, ensuring that we're storing things correctly, that we're following the manufacturer's instructions for use, and that we do have high reliability in our overall processes for medical device reprocessing. And I sort of have a phrase of never let an outbreak go to waste. Learn something from everything before us. And I think we all have a requirement and an ethical and professional obligation to say, what do we do moving forward? How do we take these lessons learned? I hope to see lots of articles that come out from the OR and SPD and reprocessing suites that talk about the challenges and best practices that are needed. One of the best ways to change clinical practice is to publish. And so there's great, publications like ISHIM and other places that have that sort of venue where you can submit that work to get it out there in the peer-reviewed literature. And then lastly is work with our colleagues, collaborate across borders, make sure that we actually are working with our local public health authorities, and also know your own data for your community so you can protect your own family. As I mentioned earlier, I want to refer you back to the CDC website, not only for your own professional use, but if you are a member, for example, of a church, or you go to a gym, or you want to go out to eat, there is guidance for every single thing, including things like if you're going to ride in an Uber or a cab or fly on an airplane. My goal is today, I hope you felt like you learned a lot more about the overall sort of state of where we are with COVID-19 infection. But more importantly, I hope that you feel like you have the tools, knowledge, and information necessary to keep yourself safe. And CDC is a great reference for that. I've also included several of the references in case you're interested. All of these are hyperlinked, and I know that they've made these available to you as well. I want to conclude my piece before we go to Q&A by, again, saying thank you. Thank you for the work that you do that in many cases is completely unknown, unappreciated, and not recognized. Thank you for the delivery of care that you actually ensure happens by having instruments and devices that can be safely used on patients in a variety of different procedures. And honestly, thank you for the sort of dedication that you put to patient safety. While the patient may never see you, the work that you do is literally vital and instrumental in ensuring that clinical care can be delivered. And so I want to say thank you for the work that you do. With that, Lindsay, I'll turn it back over to you so that we can recognize our gracious sponsor again and then go into Q&A.
Thank you so much for sharing that important information with our attendees. Thank you again to our sponsor of this presentation, DryScope Aid. There is some additional information if you click on the DryScope Aid link on your screen. We will be opening the floor up to some questions and answers. So if you would like to submit a question to Dr. Garrett related to the information that he shared, there is a Q&A widget on your screen that you can do so through. Dr. Garrett, I know that there are some questions coming through. The first one that I would like to ask, this question says, I just want to ask, in the absence of washer disinfector and disinfectant, how can we assure that hand washing the instruments are safe for use? Or is there any recommendation how we're going to do it if there is no disinfectant? Is it okay to hand wash infected instruments like COVID-19 or hepatitis B instruments?
So this would depend on what the manufacturer's IFUs had validated. So there may be automated processes, for example, and there may be manual processes, both of which may have been validated. And so I would tell you to pull the IFU, see what the manufacturer has validated. If you go outside of the scope of that, you're putting yourself and the facility at liability. So many of these places have actually done some type of manual validation. So, for example, I'm thinking of an endoscope as a perfect example that's been recently FDA studied, where there's a manual reprocessing process and there's an automated if you're using like an AER. And so if you don't have, though, the disinfectant, I would be very, very concerned about that because, A, you're deviating from your normal standard of care, and if the manufacturer has no validation data to say that your process is effective, then you've got some institutional liability there as well as, impact to the patient. The same is true if you're reprocessing things that are typically disposable like masks. There's been some great guidance that's been put out there from CDC. I've also seen some amazing tools that 3M put out there to help facilities understand what modality of reprocessing is probably the best for that type of mask. And you really want to closely follow that. I would also encourage you from a legal standpoint to print copies and keep electronic copies of that so that if there's any type of case that comes up as a result of your effort, you have the documentation from the manufacturer, the CDC, and other regulatory bodies that says, yes, this was what we were advised to do in a crisis capacity situation. Because, what we do in the conventional setting where we have adequate supply is going to be very different. And, I hope to God we never go through this again, and I hope that healthcare facilities learn something from this. But hopefully that answers that particular question.
Great. Thank you so much. Another question that did come through, should respirators be worn by staff in bronchoscopy procedures, upper endoscopy, and colonoscopy procedures?
So that's an excellent question. I think for bronchoscopies, the overall answer would be yes, just based on the high prevalence of pathogens being expelled just as the nature of that procedure. For upper endoscopy, I think the same could apply. For colonoscopy, I would have less concern, honestly, but again, if you look at best practice for procedural areas like that where there's going to be reasonable anticipated risk, OSHA is going to tell you to wear a respirator. Again, it's based on availability. So, if you look at CDC recommendations, if you have to prioritize areas where there's known or suspected respiratory aeration is where we want to prioritize the use of those masks. But for those areas, I think it would certainly be a good idea. I know the GI societies have put out some great guidance from ASG, AGA, and SGNA about this as well, a position paper including the ultimate protection of the workers. So I would certainly advocate for the use of those in those settings based on the procedural risk that might take place.
Thank you for that. Another question that came through, isolation gowns are not fluid resistant. Can they be okay in sterile processing decontamination because of that?
Yes, so the verbiage isolation gowns come from the CDC guidance, so it's not referring to the specific type per se. So certainly if you're going to have any type of splashing or anything like that, fluid resistance, not just for the gown, but for all of our PPE. So if you are looking at an N95 mask or even a surgical mask is probably my favorite example. One little test that I like to show people when I work with them on training a PPE is I have a squirt bottle and I put water in it with red food coloring, and I ask them to put on all the PPE that they have available. So that's the gown, the mask, the eye protection, the bouffant cap, the surgical shoe covers, all that type of stuff. And then underneath them, I obviously tell them to wear some scrubs that they can instantly change out of, and I spray them down. And we actually test the PPE. So to your point, if you're looking at a traditional what some people would refer to as an isolation gown, like the traditional yellow gowns that are not impervious, that's not what we're really referring to when we're doing work in the SPD setting. So the guidance is out there for regular clinical care from CDC. When we're looking at splashing or anything like that, a splash-proof or fluid-resistant gown is what's going to be necessary. The same is true for our mask as well if we're going to have any potential splashing. I know just in the last 2 weeks, I got splashed in the face when caring for a coronavirus patient. My respirator that I was wearing was a fluid resistant. I also had on a face shield over that as well and a fluid resistant gown. I have no problem at all taking care of a COVID patient with a regular isolation gown if I'm not doing any type of procedure where I anticipate that risk. So if I was just, transporting patient A from point A to B, that would be very different than if I was in a procedural area. So hopefully that answers that question for you.
Thank you so much. And we do have time for one more question. As a wrap-up, in your professional opinion, what are two critical takeaways that are vital to making the new normal in healthcare a success moving forward?
That's a loaded question. I think our normal has to slightly evolve. And I'm not one of these people. I don't believe in swinging the pendulum from one side to the other without science data or a real need to do so. And I think we also want to be careful about sending mixed signals to our colleagues. One of the things that we can absolutely do is be better prepared. And when I say better prepared, that preparedness includes us and includes our products and our processes. So, it really starts with people to ensure that we have the most highly competent people. And I think one of the areas here that could be of huge value is to cross-train. So if you're in a central sterile processing environment, cross-train with GI. If you're in GI, cross-train with another area like pulmonology. Make yourself versatile and your utility higher by knowing multiple different areas, because what we've learned here is that those that had the most skills that could be transferable were really the most valuable in this circumstance. I've got a very good friend that is a nurse that I'm trying to think of how long I think she's been a nurse for about 15 years in the med-surg environment. She has not done ICU since she graduated nursing school almost 20 years ago, and she got thrown into the ICU with 3 hours of training. Well, that's not really setting people up for success. However, if they had multiple nurses that were cross-trained, where they could essentially pull them from other areas that got closed down, like PACU, the OR, places like that, then I think that's a huge thing. And certainly SPD has the potential to be utilized in multiple different areas just based on the great expertise that you have. And I think the second thing I would say is look at sort of the general resiliency of the healthcare workforce. What I'm deathly afraid of is in the next 6 to 12 months, the rates of depression. We've certainly already, unfortunately, seen several suicides of very prominent healthcare leaders. And so the resiliency of making sure we pick ourselves up and move forward and take care of each other and ask questions like, are you okay? What can I do to help? Having human resources, having employee action plans, and available resources are all things that we really need to think about moving forward. It's hard to think about that during the pandemic, but we really want to make sure we sort of reward our bank account emotionally, physically, spiritually, whatever it is, so that we can continue to care for our patients. We can continue to do our jobs effectively with the least impact, because I think we're going to see a lot of PTSD from this. And I can certainly understand why. So I think that's something not just for us to think about, but also for healthcare leadership across the whole continuum of care. Wonderful.
Thank you for that assessment, and thank you for that very detailed answer to a loaded question. You're right about that. Thank you to everyone who joined us today. You can download your CE certificate from the certification widget on your screen, or you can click the download link in an email that will be sent to you within the next hour. Dr. Garrett, we are so grateful for your time today, for your expertise, your professional opinion on a lot of this, and all of the resources that you gave the attendees today. It will certainly set them up for success not only in dealing with this specific pandemic, but any future ones that we live through as a healthcare industry. Thanks again to our sponsor, DryScope Aid, and a huge thank you to everyone who joined us today. Thank you for taking the time out of your busy day. Thank you for what you do, and from the Beyond Clean team specifically, keep fighting dirty. Have a great day, everyone.